Dr. Christopher Barker. I'm a New Jersey licensed psychologist, and I am here holding space, hosting for myself. There's going to be times that we have guests, and I have some of those coming up. But I wanted to reflect a little more on the writing that I'm doing on a book right now. I've always wanted to be able to take an idea and develop it to a book length. The longest thing I've written previously was my dissertation, and that was kind of structured because, there's certain things that you have to include in a dissertation. Those of you who haven't done one, I'm sure you're glad. It wasn't that much of an ordeal, actually. It was like I was interested in the topic that I was doing. What I was doing was getting local norms for an American Indian population, Native American. They just basically said Indian in Minnesota, around the Minneapolis area. So I used a reservation population for part of it, and I used a magnet school in Minneapolis that was where culture was taught. So, I was going for people who were in a cultural surround. And I was using the Children's Depression Inventory, which was originally normed on, I think, like 800 white generic Florida school children. And my hypothesis was that the same things that emerge as factors, because every test it breaks down into factors. It's not just the questions and the answers. It's like they measure specific scales like depression, anxiety, how you relate depression, how you are able to experience it in your body. And my idea was that different populations from different cultural backgrounds are going to relate to their feelings differently. And difficult indeed it was. And I found that one of the first hurdles to overcome is that I did not look like them. I was perceived as European, as I was called at the time. And not in a pejorative way, but just kind of like, you're different, and they might not be able to relate to you as much. Also, some of the questions were not as relatable. For instance, a lot of children report somatic symptoms as the first sign of depression. They feel it in their bodies, and they will get stomach aches or headaches or that sort of thing. But again, one of the biggest factors that emerged is that Native American children didn't really want to talk about their symptoms. They didn't really want to explain how they were feeling, especially to a test. And I think a lot of that is culture. And a lot of that is the fact that just everybody relates things differently. I came up with some different factors than originally were seen in the Children's Depression Inventory. So as a pilot project, I sort of had some ideas of later on, like extending it to other different types of populations, but I got kind of sidetracked by life. Had a new child, and, there were other things going on. So I never did really follow up on that. Someday I would like to. So that's something for the future. But right now, what I'm writing about is how complex trauma is seen through a relational time lens. Please don't steal my idea. The book is almost done. I'm going to get it out there first, so don't. But the idea is that as we come to relate to other people, we've heard about attachment theory, and how we attach is largely related to how much time elapses between need and satisfaction, or whether there is any satisfaction of the need at all. And being able to look at this as from an infant's point of view onward, and this is something that, again, starts in infancy, but it can continue throughout the lifespan. I'm looking at how it influences things like, he texted him 5 minutes ago, how come he's not texting me back? Secure attachment, they can wait. That's like, well, whatever. I'm assuming that, he's busy. He'll get to me. Insecure attachments handle it very differently. And there are various stages of insecure attachment, avoidant attachment. You'll have to read the book to know more. It's coming along. But, it's fascinating to explore this, and it's fascinating to develop this. I'm used to writing short articles. I'm used to writing short pieces for LinkedIn and other places, and being able to look at something and develop a topic from infancy on throughout the lifespan, and also focus on what kind of therapy works and what kind of therapy is actually going to be really helpful and what therapists should look out for. And the very idea that there are some things that slide right on by us. You know, when we started doing the interview with Carolyn Joy, we talked about a trauma-informed language and how sometimes even the simplest language can either help or totally derail the therapeutic process. And it's so subtle. That's the thing. It's so subtle. Doing things like saying, "Oh, you'll feel better," or "I'll help you." Things like that take the agency out of the hand of the patient or client, if you prefer that term. And it gives them not only the perception that the help lies outside themselves, not inside themselves, but also that I have to depend on this person to fix me. And you really don't. You have all the capabilities to fix yourself. We just have to guide you. And this is the thing that therapists have to run across all the time is, first of all, how we're perceived and how much of it is transferred from previous experiences with authority figures, parents, previous therapists. I can't tell you how many times I've heard that, I've worked with somebody before, but they weren't able to get me, or they said that I was doing this or that I was doing that. So being able to get past the resistance and the transference, we are not the parent. We are sort of sitting as an authority figure because, I mean, again, like I said, I use the word patient because it sort of fits with, and I know medical model is not really very popular these days, but you go to the doctor to feel better, and that fits the definition of patient. So when people come to see me, they are going to the doctor to feel better. I do not think that I have all the answers. I do think I have some pretty good questions sometimes, and I'm always, always on the lookout and always very careful about the things that I say and how it might be perceived. And I ask people, how did that feel? What did you take from that? What do you need? Because you are the best judge of what's going on inside you. And diagnosis is a big problem for a lot of people. They don't want to think of themselves as a diagnosis. And people will come in and say, "Oh, I'm a BPD." Well, okay, who told you that? And what does that mean to you? And a lot of times it's either come from the internet or from a previous therapist. And that becomes the paradigm of how a person sees themselves and how they see their relationship with other people. And that fits in with the whole developmental model that I have. We have to be careful with what we say and what we do and how we refer to issues. I'd like to think that I do that better than some, but I'm always questing to do better. And a big part of that is checking things out. So if you're working with a therapist who consults with you, because ideally that's what it is, you're consulting, you're working together on something. I don't have all the answers. I have some good questions. Sometimes you don't have all the answers either, but you have the raw material in there for all the answers. And a lot of times I will do the whole, I guess you've all seen the internet memes of like, and what do we do when we're feeling this way? And then there's a ridiculous answer. And then the therapist says, no. Sometimes it comes down to that. And those memes are really funny. Funny because, I mean, there's a certain amount of truth in it. People will choose maladaptive ways of behaving and maladaptive ways of coping with issues. And sometimes we have to say, I don't think that's probably going to be the most helpful thing, do you? What are the likely outcomes when you do that? It's it's invigorating when somebody actually gets it and really takes what we say and either tries it and says, "Hey, that didn't work at all." That's engagement. Or if they take it and they say, "Hey, that worked great." That's also engagement. So I know I'm a little bit all over the place today, but these are the things that go into making up a formulation of any kind of theory. And I've generally found that a lot of theories of personality and theories of working with any kind of particular disorder or issue are frequently laid early on in our perceptions. We seek the answers for things that we need to understand. I do come from a background of complex trauma myself. I did a podcast on that recently. So I wanted to understand what was going on. And so I did some research, and I was first introduced to the idea when I was doing EMDR training. And I said, what makes this happen? So I think I came up with an idea that I would sort of be able to apply to myself, and hopefully other people can apply to themselves too. More on this as it develops, but this is me sort of talking about what it's like to be creating something, putting something together that maybe people hadn't looked at in a certain way before. The fact that we care to keep trying matters. Once upon a time, to be a psychologist, you didn't have to take any continuing education credits. I always had a problem with that. And now we have to take 40 a year, and they include domestic violence and opioid abuse. They are specialties that we have to really focus on. Also, ethics is becoming big. All things that we really need to stay current with. I love going to workshops. I think they're terrific. And, I recently did something about the evolution of psychotherapy conference. I'm going to one in March that Dan Siegel is doing, and I'll be probably going to several more during the course of the next couple of years. But it never gets less fascinating. And I guess that's, when you found something that really works for you. So follow your dreams, follow the things that work for you, try to understand yourself, try to understand yourself in the context of how you work with people. And I think you'll be doing a good job. This applies to both the therapists out there who might be listening to this. I hope some of you are. And also to the people who are working with the therapists. Have a dialogue, be able to relate, and be able to feel like you have a working relationship with this person. They don't have all the answers. You have answers, but again, it's a matter of putting two and two together. I'm Dr. Christopher Barker. Thank you for holding space for me while I ramble through this. And again, more on this soon. And also more guests coming up in the next week or two. If you enjoy this sort of content, hit like and subscribe. Leave comments, leave questions. I do try to get to those as often as I can and answer them. I'm always open to criticism or new ideas. Praise is good, but it's not absolutely necessary. In fact, I like when I'm challenged and people will say, well, what about this? I've had this experience and that kind of goes against what you're saying. That's great. Tell me about that. We'll work on that. We'll try to introduce some ideas. I'm, there's a lot that I don't know, and I don't know what your life has been like. Thank you. And hope you see me again soon.